I would like to invite Dr. Sumit Ray, Dr. Amit Prajapati, Dr. Chirag Chatwani to chair this session.
So there is a special announcement.
Mahindra Electric SUVs from President Motors are there. There are 4 cars, 2 BE6 and 2 XUV9E. If you are free, please have demo and ride. The special gifts for you and 25k discount on behalf of Gujarat Criticon 2025. It's a future and luxurious car. So forum, let's move ahead. Role of intensive care, professional beyond intensive care.
ICU skills don't stop at the door. Their impact spreads to every floor. In crisis or calm, they are always there, extending strength and specialized care.
To dive more, let's hear from Dr. Maharshi Desai.
This lecture of mine is a bit different because I'm not going to talk about academic things. I'm just going to talk about how we were practicing. On to my lecture, I would, for the benefit of a young budding intensivist out there, just go briefly through the evaluation of intensive care and the intensivist in India and in overall the world above. The ICU started springing up in, I think, 1960s and 70s in US and Europe. In India, the ICU started around 1980s and 1990s. So when the first ICU started, they were only the ICUs and the sick patients inside it. There were no intensivists. And then gradually, the people who were finding those patients challenging and they wanted to care about sick and critical ill patients, they started working into those ICUs. So those initial, our pioneers of intensive care in India, they were working in the ICU, but probably they were not aware of themselves as intensivists. The word intensivist probably came later on. So there was a period when there was an ICU, but there was no intensivist. Okay. So when the population of intensivists started proliferating, then there was a debate as to what is the need, what is the role of an intensivist in the ICU. So if I tell to our young budding intensivists that there were actually trials of role of intensivist in the ICU, they would probably not believe it today, but yes, there were the trials which tried to show whether the intensivist was relevant to ICU or not. And guess what? What were those trials' results? So for every matrix that they tried to evaluate, be it length of stay, be it mortality, be it infection, everywhere, when there is an intensivist in the ICU, the matrix was way better than when the ICU was without an intensivist. So from there, wherein there was a possible role of intensivist into the ICU, now here in 2020, I am talking about role of intensivist beyond and above the ICU. So let us start. Now, this lecture is only for visiting, it is only for full-time intensivist, and this probably does not apply to a visiting intensivist. I would not like to go into much detail and debate about the breed of visiting intensivist in year 2025. Now, before we deal with what an intensivist does, let us first deal with what an ICU is. What is an ICU? What is the definition of ICU? Can anybody tell? Forget it, I will tell. So, ICU is an organized system for provision of care to critical ill patients that provide intensive and specialized medical and nursing care and enhanced capacity for monitoring and multiple modalities of physiological organ support to sustain life during the period of life-threatening organ system insufficiency. अरे भाई कहना क्या चाहते हो? What is an ICU? Correct? The ICU is very simple. An area of hospital which is led by intensivists, which treats sick patients with proper monitoring and proper treatment, which is relevant to that patient. That is, in simple, an ICU. Now, why this is important? Why this Baba Ranchhod's definition of ICU is relevant to us in year 2025? Let us understand that. So, as I said, that intensivists were initially focused on managing critically ill patients within the ICU. So from the evolution of ICU and the intensivists were focused in the walls of ICU. Now this is the time to think beyond it. Why? Because the modern healthcare demands a continuum of care right from early recognition. So before the patient comes to the ICU, to the patients going out of the ICU. And so the intensivist expertise are now believed and to be cared for by the entire hospital system. So the hospital systems now are getting aware of the expertise of the intensivist, which is not to be confined only in the walls of ICU. And they want this expertise to extend over and beyond the ICU care. Now, whatever I'm going to talk about in this lecture, probably you are already doing it or at least are aware of it. So in that way, I'm not going to talk anything new about it. And again, depending upon which level of ICU you are working in, level 1, level 2, level 3, some of it may not be applicable to you. But so, as I said, it depends upon which scenario or which environment you are working in. So this was an article by G.L. Vincent and Marin Osterman, recent article. They talk about ICU without the walls. Now, this is the concept that we need to understand. So we as an intensivist were focused in the ICU. Now, we want to spread our expertise, the protocols that we have perfected within the ICUs and now applied to the hospital in general. And that is probably the need of the hour. And for that, we need to break this mental barrier of the ICU walls. We want to bring the intensive care to the hospital and not the patient coming to the ICU for intensive care. So there is a difference, there is a change in the concept of providing the incentive care. It is not limited only to the walls of ICU, it is now going beyond the walls of ICU. Now, there would be, see, because this is a new concept, it's going to have its challenges, it is going to have its potential benefits also. Now, I can go on for this, but what I would like to talk about is the cost effectiveness. See, why we want to do that? There are a lot of reasons for it, and one of it is the cost. So, can bringing an intensive care outside the ICU to the each and every patient who might potentially require in the hospital system, does it worthwhile? Is it cost effective? Maybe. It may not be. Why? Because, yes, if you are bringing less patients into the ICU, that is definitely cost effective. But then you need to provide an upgraded level of care in terms of nursing, in terms of monitoring, in terms of medical officers into the ward. That would increase the cost of it. So as far as the cost effectiveness is concerned, maybe it might increase, it might not increase, probably the time will tell. But yes, it is definitely giving a try, and it is, as I said, it's the need of the hour for the time being. Now, when we talk about critical care outreach in the hospitals, there are multiple layers to it. First and foremost would be a critical rapid response team, a kind of a code orange kind of a thing. So whenever there is a problem in the hospital, a code orange is triggered, and the team, which is led by an intensive care, would go on and assess the patient and things like that. But that's not the only thing. There are, as I said, multiple layers to it. Say, for example, if I talk about myself, I'm into oncologic critical care. So what I do is, say for a patient who is AML induction therapy, on day one I introduce myself, that look, I'm Dr. So-and-so, I'm a critical care specialist. You are in the ward. My role is to see to it that you don't land up in the ICU. Okay, so this is an extension of critical care into the ward before the patient gets critically ill. Okay, so this is how we finish. I give another example. A 90-year-old lady, fragile, multiple comorbidities, now not presenting with an IT fracture. The orthopedic surgeon wants to do a surgery on her. The patient is in ward. My role is to look after the medical part of it so that she does not land up in the ICU. That is again an extension of critical care which is beyond the ICU. Okay. Then there is care of emergency ward patients. Now, probably depending upon the scenario in which you are working, you may or may not have a specialized emergency physicians. So if you don't have an emergency physicians, you would be required to do the work which is to be done in the emergency. I give you some examples. Resuscitation, be it shock, be it trauma, thrombolysis in stroke. Everybody understands that you need to do a thrombolysis in stroke as early as possible. But who would move the things? Who would become the lubricant in the system to get the things done rapidly? It is the intensivist. So this is where a role of intensivist would come to kind of get the things done early in the emergency ward. Another aspect is code blue team. Code blue team again is a standard practice wherein an intensive care person would be looking at the code blue responses and they would be leading into it. Maybe the anesthetist or somebody else, but by and large it is the intensive care person who would be leading a code blue team. Next very big area is the post-ICU care. Now see, what has happened is that because of improvement in critical care, we are able to survive a lot of patients who would otherwise die. But what happens in process is that they land up in a limbo, wherein they are good enough not to be in the ICU, but they are not good enough to be shifted to home. So they will land up in a no man's land. They don't require an ICU stay, but they cannot be discharged home. So they land up in either a HDU or a long-term acute care. Examples, stroke, head injury patients, oncology patients, geriatric patients. So they really don't require an ICU care after a certain point of time. But then, where do they go? Probably ward is not geared up for their care. The relatives don't want to take them home. So then the responsibility of caring for such patients do fall upon the intensive care personnel. Then there are a lot of patients who have been in the ICU for a very long period of time, and for them, managing the post-discharge scenario also falls upon the intensive care personnel. Now, end of life by default comes to the ICU people. But not all of the end of life decisions are made in the ICU. Again, oncology, I give you an example. Once a patient reaches a threshold wherein it is now decided that this patient would require an palliative care only, the oncologist probably, and justifiably so, loses his interest because he has nothing more to offer for those patients. Now, who would then take care of these patients? Then again, by default, it is the role of intensivist, wherein they need to come and do the palliative and end-of-life care discussions, and they still need to manage it. It's not that you just leave it alone. You have to at least have a symptomatic management of all these patients. Now, this all things can be doing in the ward. Transport of critically ill patients, again, depending upon the hospital policy, either it is the intensive care team or the anesthetist team, or there is an dedicated person who would be doing it. So again, it is depending upon the institutional practice. You might or might not be called upon to take care of this category of patients. organ transplant. Now, with more and more organ transplant happening, we as an intensivists are called upon to host a cadaver, and apart from the clinical part of it, there is a lot of regulatory and other hassles which go into the cadaveric transplant process. Of course, there are transplant coordinators who would do this job, but still as an intensivist, you have to manage those formalities, nitty-gritties also. And the other end, any person who is going to receive that, you would be also called upon to manage and coordinate with the organ transplant recipient team. So this is the role which we have now been getting more and more involved into. Disaster management. Recently we had this Air India crash, and Apollo Hospital being the nearest to a tertiary care hospital, nearest to the airport, we were called upon to be on the standby for this disaster. And so it was informed to the hospital that you be prepared, there is an air crash. And guess what the hospital tells to be prepared? It is the intensivist. They don't tell the surgeons, they don't tell the anesthetists. They would tell the intensivist, okay, this is an air crash, be prepared, we might get the patient. So for any disaster which happens in the local area, you would be called upon as an intensivist. Whether the patient requires ICU or not, that's a different thing. But you would by default become a team leader in such a disaster situation. I remember in 2006, there was a Mumbai train blast. I was in the ICU then, and the patient started trickling in. So who is the first responder for those patients? The first responder by default again becomes the person who is in the ICU. Those patients need not be in the ICU for the intensivist to come into the picture. Okay. The other very important role is that of a pandemic. We all have been a part of COVID epidemic. Now, we as an intensivist were called upon to look for the epidemic. It was not pulmonologist, it was nobody else. And believe me, for any other, so this was primarily a respiratory problem, but if there is anything else, then again the intensivist would be called upon for the primary coordination of disaster or pandemic management. And being an intensivist, whether you like it or not, you would also be called upon to do a non-clinical roles also. You would be serving as an ICU director or a member of an hospital committee and participate in various hospital-related protocols. Some of it, you don't want to do it, but you still have to do it. You cannot avoid being a leader in an antibiotic stewardship and infection prevention programs. Tele-ICU is one area wherein intensivists do have a role. Dr. Raj is a pioneer into it. But again, as I said, you may or may not be required to do that. Now, very briefly, before ending, I would talk about this concept of a hospitalist. Now, the concept of hospitalist is actually an old concept. It's there in the US, wherein the hospitalist is an indoor specialist who were basically physicians, who were managing the indoor hospital patients. Now, if you extend, and as I said, there is a need for a person to manage those patients in the hospital, I think that the intensivist is best suited for this role of the hospitalist. And how this hospitalist is different from a primary care physician. So as I said, the hospitalist works exclusively inside the hospital. The primary care physician is sitting in his office, is doing his OPD. The hospitalist would be looking after the patient from admission till the discharge, and the primary care physician then would be looking after those patients as a long-term continuous care. They would be focusing on the acute medical condition. A hospitalist is better tuned for infection control, nutrition, any other things than a primary care physician. It does not matter whether the patient is in ward or in ICU. And because they are full-time, they are available quickly and within the emergency. And how do you differentiate a hospitalist from a specialist? The cardiologist, neurologist, nephrologist, gastroenterologist, so on and so forth. Okay. So how do you differentiate between? It's a bidirectional collaboration. You know, the specialist would call upon the hospitalist for a problems beyond their specialty. So cardiologist might call upon the hospitalist, the patient might be in the ward, that look, this patient is breathless, it is not cardiac. Now you tell me what it is. It's pneumonia, it's decay, it is your problem, you solve this problem. And the hospitalist calls the specialist to coordinate for a very specific, organ-specific problems. So a hospitalist and a specialist then work in tandem for the patient management. So lastly, the intensivist is like a Swiss Army knife. Okay, beyond their ICU responsibility, they are called upon to look after lot many things. You are doing it, and probably you would be required to do it. So think of yourself as a person who is looking after the patients in the hospital rather than patients in the ICU. Okay. So let us all be ready for this new paradigm change in the way we look ourselves and way we look at the ICU. Thank you. No comments. I should be glad, or
My only concern is, and a very good talk, the only worry is the intensity of the intensivist's watch in a controlled environment, relatively controlled environment. From there, an intensivist puts in an intensive watch, and that is why they are an intensivist, right, over the patient. From there to become, go out of that area, and will it kind of dilute the intensity of the intensivist's watch is my worry.
Yes. So it is not about dilution of intensivist or an ICU. It is about strengthening the patient care in the ward. I mean, what is the harm of taking a concept of fast hug BID, which we use commonly in the ICU, and apply to the wards? Okay, so it is about moral of the story is as far as if you can tell it.
And you keep a watch, an extended watch, but I mean, concerns apart, what you have said about, Manoj, about this, yes, of the hospitalist in the US, the concept of the hospitalist is not of an anesthesia background person. It is usually a internal medicine person who has a physician who takes care of these patients outside the ICU, all hospitalized patients, while the intensivist takes care, So I would think that probably, and also, I mean, not trying to differentiate, I come from an anesthetist background into critical care. I think that obviously when we become intensivist, a medicine person, a pulmonologist or an anesthetist, we learn many other aspects from our base field. But as an anesthetist doing critical care, usually the way our training is, our focus is in a controlled environment, to tell you honestly. That's why my question came to you about. So I'm not saying that it is not possible for the intensivist to look out, but the worry will be, even if it's an internal medicinal person looking out as an hospitalist, but will it dilute my, I mean, you answered it, but that was my anxiety.
Yeah, so it's not that one person could do everything. It is about expansion of the team. You know, it is the concept of bringing the intensive care outside the ICU, and as I said, the patient is on NORAD, patient is on anti-G. This patient cannot be in ward. So with the caveats applied, we can extend the care to the patients in the ward.
Thank you, Dr. Desai.